Good morning.
Morning.
Co-chairman, my dear friends, colleagues, faculty, and the keynote speaker. Very
My professor.
pleasant personality. I am Dr.GJPurohit from India. Low back pain, very common subject, but it has become headache for all orthopedic surgeons. My experience of 35 years, very commonest but uncommonest event cases we will see today. Very unusual, interesting, surprising, rarest of rare unique cases. Nothing to declare. You all listen everything we know, you know better than me. Very unfortunate case faced in 2016. In India, there is a custom and habit of sending WhatsApp for getting opinion charges. So it is very dangerous to be open on that. This is one example. One of my patient relative called to see the WhatsApp patient admitted in some town near his village in Gujarat for conservative cocktail therapy. For acutely painful radicular pain, both legs, MRI was typical of the disc prolapse, lumbar traction, started cocktail and physical therapy and steroid. They called me, told that surgery is advised by local orthopedic surgeon, otherwise he may develop cauda equina, paralysis of both the legs. Relatives were very anxious, worried to undergo surgery. Again they called, patient suddenly developed weakness, numbness as the orthosurgeon told. So they were very much anxious, surgery was advised in emergency. Any consultation, I did not commit, let your doctor decide what to do. He is the final authority. So they asked me to transfer to my hospital. Next day they called, there is bluish coloration of the toes and developing black discoloration. I suspected it was vascular catastrophe. I asked that you immediately consult your doctor to take the opinion of the CT, but there was no available CT surgeon in their city. So next day he started developing black cyanotic patches on the feet and leg, gangrene like picture, and I suspected it is a LERICH syndrome, cauda equina, the aortoiliac occlusive disease affecting the distal abdominal aorta, patient with a triad of claudication, impotence and absence of femoral pulses, acute pain, paresis, paresthesia, pallor. So this was the actual diagnosis which was missed. By the time patient was brought to me, there was complete gangrene of both the legs below knee, and unfortunately I had to do bilateral amputation. So never give opinion on WhatsApp, always look for the pulse in the feet. LERICH syndrome as cauda equina syndrome, PubMed Central misdiagnosis, while LERICH syndrome typically presents chronically and acute thrombosis of the terminal aorta can present with symptoms that mimic cauda equina syndrome, including sudden bilateral leg pain, weakness, numbness, and sometimes weakness. The absence of femoral pulses is the hallmark of LERICH syndrome, is overlooked in favor of neuroimaging. I remember during our residency, there were Backache clinics in the evening. So our mentor used to tell always, have you seen pulses? Have you seen pulses? This was the routine. So both have similar symptoms, both cause severe leg pain, weakness and sensory deficit. But the key differences between the two are cold, pale, pulseless limb, whereas cauda equina syndrome often presents with firm legs and palpable pulses. Another male in 1987 brought from Rajasthan, nearby state, near Gujarat, poor farmer, history of minor injury to the foot, untreated wound. He was referred for back pain, having severe back pain, deformity, stretcher bound, no spinal injury or fracture vertebra. In 87, there was no facility of MRI or CT scan, only X-ray, which was normal. There is increased lordosis of the spine with severe muscle spasm and spasm was board-like rigidity. There was no definite tenderness, no TT prophylaxis history available, and this was referred for back pain. I suspected it to be opisthotronus, and on careful examination, tetanus spasm was suspected, diagnosed, confirmed by irritation test. So this is another. The diagnosis of tetanus we all know: Rhizus sardonicus, lockjaw, opisthotronus, neck rigidity. This was basically patient presented as a opisthotronus. So general physician was consulted. There were no super specialists at that time, 1987. Treated for 3 weeks, good sedation, cocktail therapy, nursing care started, avoid stimulation. There were not many complications. In 3 weeks, even tracheostomy required to be done. And patient was to be discharged next day after 18 days, but suddenly developed hyperpyrexia 170 degree because of the brainstem edema in the case of tetanus. So antipyretic was given and patient suddenly developed severe perspiration, hyperhidrosis, and was severe vasodilatation, shock, pulseless, BP-less. Mortality is very high in such cases, but luckily I was present at that time. Immediate resuscitation, venesection, vasopressor, fluid therapy. To our good luck, patient recovered, survived, and went home in good condition. This was the era of primitive ICU facilities. There was no review of literature available, no internet at that time. Recently we reviewed the literature, September 2020. Tetanus is a fatal disease that may present a common clinical symptoms such as back pain. This case is presented with the aim of bringing tetanus to clinicians' mind and recommend tetanus welcome in such cases of unusual back pain, giving prompt relief. And the case presented was a 59-year-old man admitted to neurology clinic with back pain in recent 2 weeks. His pain was intermittent and was becoming more frequent, severe as the time goes on. Patient previously admitted several clinics with back pain resistant to analgesic drugs, and rest of the signs of the tetanus were negative in this patient. Another article, Emergency Medicine 2007, a patient present with low back pain with diagnosis of tetanus. Female 47-year presented, severe back pain, spasm, found to have opisthotronus. After 40 days of intense care, patient did not recover and succumbed to death. So tetanus is a fatal disease. All should be aware of typical and atypical presentation of tetanus, such as back pain, and also tetanus prophylaxis is important. The tetanus presenting as an isolated or pure lobe pain is an atypical and deceptive clinical scenario. The focal onset in lumbar muscles, known as localized tetanus, can lead to significant diagnostic delay and account for 30 to 50% of all the cases. In these cases, the patient presents with intense progressive and woody rigidity of the muscle spasm. So pathophysiology is Clostridium tetani. They secrete tetanospasmin, travels via the retrograde axonal transport to spinal cord segments supplying the lower back. And instead of immediate generalization, the toxin initially inhibits the Ranson cells only in the local motor neurons, causing continuous muscle contraction and agonizing pain. So this is the diagnostic tab. Because the pain is severe localized, it is frequently misdiagnosed as an acute lumbar disc herniation, transverse myelitis, or severe muscle pain. So this means there are cases reported in these various journals, including Indian Journal of Orthopedics. High index of suspicion for tetanus when back pain is accompanied by board-like abdominal rigidity or inability to sit up without entire trunk moving as a single unit. So in 38-year retrospective context, recognizing these miracle cases where common symptoms mask lethal pathologies is vital. Any case of severe back pain with unexplained muscle woody stiffness and a history of soil contaminated injury should be treated as tetanus unless proved otherwise. The third case in 1995, female aged 40 years, our nursing in charge of our hospital, came with the severe back pain since morning. There was no significant history of sprain or heavy weightlifting or chest pain. All the examination findings were normal. Usually we do not advise ECG straightway in back pain cases. But for her, I advise ECG and admission to ICU by my 6 friends. And ECG saw inferior infarction. She was immediately admitted to ICU, and emergency measures saved her life. Another case, male aged 35 years, referred from CMO for back pain and leg pain in cold winter season. Patient was his clothes were wet with the perspiration. Patient then was lie down, pulseless, BPless, admitted in ICU, found to be a case of acute MI in shock. Directly shifting the patient from CMO to ICU would have saved patient's life. Unfortunately, patient succumbed. So acute upper back pain, atypical symptom of AI, is more commonly encountered in women, elderly, diabetics. Delayed diagnosis is associated with high increased morbidity and mortality. This is a case report. Many researchers have reported that upper back pain and fatigue are commonly reported symptoms during ACS, and up to 30% of the patients do not experience chest pain at all. Atypical pain is frequently defined as epigastric or back pain or pain that described as burning, standing or characteristic of indigestion. They may present. Can a heart attack cause back pain? Recently, there are newer, younger patients have come with the sudden death due to MI. This could be the reason, because back pain is often related to straining from heavy lifting or poor posture, but back pain can also be a symptom of heart attack. This should not be missed. So awareness about unexplained death in youngster depicted as sudden MI, suspect and diagnose the treatment and treat that accordingly. Fifth case, male aged 47 years, history of road traffic accident between bus and truck before 3 months. Then he came before 3 months. Patient was ambulatory, back pain with both leg pain, radicular pain, neurology was normal, VAS 3, ODI 5. Surgery was advised by somebody. Patient not convinced, went to spine surgeon, plantar extension, DTR exerted, cervical spine MRI, so compression of the C4-5 with coordination, cervical surgery was advised. Patient was not convinced, and weakness of both the upper and lower limbs. Patient landed to me, incoordinated gait, mild headache, quadriparesis, grade 3. I was not convinced. Querying cranial nerves involved, and patient had mental confusion. We advised CT brain, and there was bilateral subdural hematoma. This was 3 months old. So patient had complete quadriplegia. Then was consulted. He was operated by bilateral foraminal decompression. Both the hematoma evacuated, and fortunately patient survived and recovered completely. On the next day he was walking. Last case, 1986, sixth case. Parents of 6-year-old child complain of back pain in their 4th decade, which is not common. In 4th decade, people face pain. So weightlifting, I asked them what is the cause of weightlifting. They told that I have a child who is getting older and older but is not able to walk. So we have to lift him here and there. Therefore we are getting back pain. This was because of the congenital. I asked them to bring the child next day. And this was the child actually. Having 3 legs, triplication. The middle leg was anesthetic, powerless. This was short but sensation and power leg. There were some other abnormalities also. And there was trifurcation of the aorta. The child was operated walking on 2 legs, and the back pain of the parents was relieved after the child walked. This was the imputation I added to the medical history. So what is the status of back pain? It is headache for all of us, because as the time passes we see so many cases of back pain. They are neglected. Even wife neglects backup of the husband. you apply your mobile phone and get it vibrate, so you will get relief. So nobody listens to the patient. History taking, lacking, mostly examination. We just touch your toes, back, or like that. No lying down in examination. Pulsations difficult. I always ask my assistant to see for the pulsations. Your pulse distally. This is very important. The patient is something from teacher to student, student to physiotherapy, and the cycle goes on. We develop another department, Ayurvedic and occupational therapy, and some for such patients. So when patient come third, fourth time, we send him for the massage, and there was separate department for that. So spinal surgeons are very careful to get endoscopy cases. They are very happy. Single specialty, multi-specialty approach. So do not neglect back pain cases. Detailed history examination is important before investigation. People have a habit of taking MRI, X-ray, and give opinion. Examine carefully to find out the rarest of rare condition. Never depend on repairs. Clinical is must. Always give TT prophylaxis, prevent fatal complication. Always look for distal peripheral pulses in all cases of back pain. Never commit on WhatsApp. There are so many friends, family. Out of box thinking of sixth sense is most important. Again, you are welcome to Ahmedabad, Gujarat, India, IOACON Academic Feast, IOACON 2026 in December, first week. Thank you all, and nothing to declare except many thanks to the organizers of the 10th Annual Congress of Orthopedics, our stalwarts, and you all who have listened me carefully and peacefully. Thank you all.